Hi, good afternoon. Thank you, Dr. Vikas and its team for inviting me over here to discuss a very important topic which we often tend to forget during the main treatment of the patients with the cancer. So today we'll be discussing about 2022 International Clinical Practice Guidelines for the treatment and prophylaxis of venous thromboembolism in the patients with the cancer. We know that the 20% of the patients of the cancer, they have some sort of VTE, and 1 in 5 those patients who have VTE have the cancer, and it VTE is the second leading cause of the death in the cancer. We often tend to forget and see the exact true burden of the patients of the VTE in medical oncology. It's the tip of the iceberg. And if there is a data to suggest that 60 to 70% of the fatal PE are detected on the postmortem, which are not otherwise suspected or the diagnosed. So it's a very important for us to diagnose the VTE very in the early stage. There are a variety of the risk factors why the VTE is developed in the patients with the cancer. They are treatment related, they are patient related, cancer related, and there are certain blood parameters which are also important. If a patient who is going a major pelvic surgery or major surgery, the patients often have some central venous catheter or PICC lines, certain chemotherapies, and these are the treatment-related factors which increase the incidence of VTE. While elderly patients, obese, those who have been smoking, those who have been less active with congestive cardiac failure, are the patients where there is an increased risk of the VTE. GI malignancies, lung cancer, and the other hematological malignancies per se have an increased risk of VTE. And also the treatment related factors add and contribute to the increased incidence. This is a typical course of a patient of a cancer. When the diagnosis is made, often they undergo surgery, some sort of biopsy, hospitalization, chemotherapy. There is a 6-fold increase in the risk of VTE. Once the patient is treated, is in remission, the risk is as normal as with anybody else. But again, when the disease recurs or metastasis, the risk of VTE also increases. Even in chemotherapy cycles, the data from cycle 1 to 3 also shows that as you progress further, the risk of VTE development, even in the ambulatory cancer patients, also increases. Certain drugs like cisplatin, L-asparginase, we all know that thrombosis is very common with the patients who are receiving the L-asparginase for the leukemias. 5-fluorouracil and tamoxifen aromatase inhibitor are also having an increased risk of VTE when the patients receive these drugs. We know that VTE during chemotherapy has significantly worse outcome and the overall survival. So even primary treatment patient may be responding, but because of the VTE, there is increased risk to the life. To assess the risk of VTE, there is a Khurana score, and that, depending on the risk category, either low, intermediate, and high risk, the patients with the cancer can be further managed, and the VTE treatment-related mortality can be avoided. So let's look into the ITAC guidelines in various clinical settings. The first I will discuss is prophylaxis of VTE after cancer surgery, and then we will go into the what happens with the medical oncology patients. So ITAC guidelines in 2022 suggest that any patient who is undergoing surgery should start with the low molecular weight heparin once a day, 2 to 12 hours preoperatively, and should be continued at least for 7 to 10 days. Patient can also receive low dose ultrafractionated three times a day heparin, provided if they have some renal failure. There is no data of an oral anticoagulants in this setting. So the drugs what can be used for the prophylaxis before the surgery are dalteparin, enoxaparin, and fondaparinux. But most important thing is that the creatinine has to be normal, or their creatinine clearance should be above 30. If it is below 30, it is a contraindicated. Those patients who after surgery, when they go home, that they become ambulatory and at risk, even out of the hospital, primary VT prophylaxis is recommended at least for the 4 months postoperatively in the patients who have a high risk of development of the VTEs. And the drugs which are oftenly used could be dalteparin, enoxaparin, apixaban, these are the oral apixaban these are the drugs which can be used for extended VTE. But there are certain contraindications to use VT, which are very important. One should all know. There are some absolute contraindication. There are some relative contraindications. If somebody is having active bleeding, platelet counts less than 50,000, having abnormal PTT, some indwelling neuroaxial catheters, if somebody is going to receive a lumbar puncture, such patients are contraindicated for the VTE. Absolute contraindication due to mechanical prophylaxis are because of acute DVT, and relative is like large hematoma. So one has to be aware of these settings. Let's see the prophylaxis of the VT in medical oncology patients. So ITAC guidelines suggest that those patients who are having a high risk based on the Khorana score and their creatinine clearance is more than 30 ml per minute should receive either low molecular weight heparin or fundaparin. DOACs are not recommended routinely. These are direct oral anticoagulants, are not recommended as routinely because that's a 1B, but there are a lot of studies now which are there that if the patients have a locally advanced or metastatic pancreatic cancer, having low risk of bleeding, they can be given DOACs like rivaroxaban or apixaban. So what are the drugs which can be used for the patients in the medical oncology when they are hospitalized or they are in the outpatient? Deltaparin, enoxaparin, fondaparinux. These, again, remember that your creatinine clearance has to be above 30. And if the creatinine clearance is less than 30, unfractionated heparin is the drug of choice, which has to be used every 8 hourly, almost 7,500 units. And those patients who are ambulatory can go on the oral or the subcutaneous deltaparin, enoxaparin, or rivaroxaban and apixaban. These are the drugs which can be used for the ambulatory patients. For the patients who have less creatinine clearance, less than 30 ml per hour per minute, and the platelet counts less than 50,000, one should avoid the oral DOACs. Prophylaxis for the patients who have a catheter-related thrombosis, and ITAC guidelines are very clear that for the patient, if somebody is having a catheter, one should not do an anticoagulation as a routine prophylaxis. If the PICC lines have a higher chance of developing VT as compared to the ports, so ports are always preferred as per the ITAC guidelines. And if you put the central line or the implantable port on the right side in the internal jugular vein, as compared to the distal extremity, the chance of having a VT is lower. If there is an established catheter-related thrombosis, there is absolutely no clear-cut guideline that you should go ahead and remove the catheter. If you want the catheter to be preserved, you can preserve, start anticoagulants, and continue for at least for 3 months or even longer if you want to keep this central venous catheter in place. You can use either low molecular weight heparins, deltaparin, enoxaparin, or you can use the DOACs, which are oftenly used for the oral as an oral anticoagulants. And if somebody has got an established venous thromboembolic event, ITAC guidelines suggest that in the initial period of up to 10 days, low molecular weight heparins are preferred, which could be used either once a day or twice a day. The patients who are having some GI or GU malignancies where there is an increased risk of bleeding following oral anticoagulants like rivaroxaban or apixaban, if there is no bleeding, one can use even these drugs even in the first 10 days and can continue afterwards an oral one. Again, standard that if the creatinine clearance is less than 30, do not use. If the platelets are less than 50,000, do not use the oral DOACs. What happens after first initial 10 days? So the patients who have an established VTE should receive treatment at least for 6 months. And the drugs which have been used again are the edoxaban, rivaroxaban, and apixaban. The patients of the lung cancer, if suppose they are receiving the TKIs, if the patients who have GI malignancies, typically like who have undergone the gastric resections, these are the patients where one has to be very careful for the absorption of the drugs as well as the internal bleeding. So drug-drug interactions are very important if somebody is on DOAC, and GI absorption is another issue one has to be taken care into during the DOAC therapy. The duration of maintenance is minimum 6 months. If somebody wants to continue after 6 months, can get continued depending on the risk benefit ratio and the tolerance and drug interference and patient cancer treatment activity. What happens when you treat the patient of a VTE and there is a recurrence who have in the patients with the malignancy? There are three options as per the ITAC guidelines that increase low molecular weight heparin by 20 to 25% or switch to DOAC. You can use direct oral anticoagulants. If suppose you have been using DOACs, then you switch to low molecular weight heparin. These are the recommendations, or otherwise you can use vitamin K analogs. If you have been using those, switch to either DOACs or low molecular weight heparin. So in summary, I would say that the patients of cancer who have a thrombosis is a common event, and one has to be very careful because it affects the patient's survival. There is increased mortality and morbidity. Patients who have an advanced disease and who are receiving chemotherapy or TKI therapy have an additional risk of development of VTs. Primary prophylaxis is not indicated for the patients who are otherwise not high risk based on the corona score. But if the patient has certain high risk factors, one can go ahead with the primary prophylaxis. If somebody has got an established VTE, the treatment can go on for the 6 months, where oral DOACs and low molecular weight heparins can be used. Patients who are undergoing surgery can receive an extended prophylaxis up to 4 weeks from the date of surgery. And during the hospitalization, if there is an immobilization, the patient should also receive the primary prophylaxis during the therapy. Thank you very much.